influence communication. Communication in patient care. In this study done here at Stanford, operating room staff were interviewed on their opinions as to what factors promote effective communication in the OR. They found that OR team members, regardless of role, felt that team familiarity, clear role expectations, and formal communication were vital to effective OR communication. Importantly, it was also noted that providers feel disengaged from the rest of the team when they are not recognized by their names. I found this particular passage from the study striking. They wrote, many attending anesthesiologists noted that the dynamic with attending surgeons was fundamentally depersonalized, with few surgeons calling them by their given name and instead referring to them as anesthesia. This sense of depersonalization left them feeling disengaged from the rest of the OR team. This disengagement led to confusion and breakdown in effective communication when, for example, the anesthesia team did not inform others that another anesthesiologist would be taking over the procedure. This next study explored dynamics amongst providers in order to understand what types of behaviors led to more efficient care in an emergency room setting. The authors of this study concluded the use of team members' names was one of 5 out of a list of 20 different behaviors that were positively tied to efficiency. Using names built trust and engendered a stronger work ethic amongst the emergency room providers, leading to more efficient care. We all recognize that effective communication is important in the OR. Communication failures are estimated to be the cause of 30 to 70% of non-technical surgical errors. Communication failures can impact efficiency, performance, and morale. Omissions, misinterpretations, and conflict arising from poor communication can negatively impact outcomes. What makes communication effective or not effective in the operating room is obviously complex and multifactorial. However, knowing the names and roles of team members is fundamental to good communication, especially in stressful or emergency situations. In the OR, we are all focused on our individual tasks. Our colleagues may not hear questions or commands that are directed to them when their attention is focused elsewhere. Non-verbal ways to get attention, such as making eye contact or tapping someone out, are not as easy to do in the OR as they are in other settings. So using proper names is the best way to get someone's attention during surgery. Recognizing the importance of knowing the names of others in the operating room, the World Health Organization recommends that all team members introduce themselves by name prior to the start of surgery during the pre-operative timeout safety protocol. In order to be able to call our colleagues by their names, however, we must be able to recognize and identify who they are. This can be difficult in the operating room for a variety of reasons. Most importantly, visual cues that are helpful in identifying others are missing, as hats and masks obscure facial features and gowns cover name badges. Even for those not in scrub attire, name badges are small, making it difficult for those at the operating table to read from a distance. Whiteboards can be helpful, but they don't always provide a full list of names and can be hard to read. Additionally, team members can change during a case, adding to the confusion about who's who. Let's talk a little bit more about name recall. Several studies have shown that even after introduction at timeout, name recall is poor. In this study from 2017, the authors asked surgeons, anesthesiologists, and nursing staff to recall the names of their team members following surgical cases. In this study, participants wore standard operating room attire, and introduction of team members by name was done before each case. While members of the same team were able to recall each other's names most of the time, the authors report that name recall across different teams was poor. For example, surgeons were good at remembering the names of the other surgeons in the case, but not so good at identifying staff on other teams. Specifically, their data showed that only 30% of anesthesiologists were able to identify the surgeons and 19% of surgeons able to identify the anesthesia providers. Why is name recall so challenging? We are presented with multiple names to remember at timeout, and then our attention is focused on the task we need to complete during surgery. It's difficult to remember names of colleagues whom we may not know well or are meeting for the first time once we start concentrating on the case. So how can we improve recognizing our colleagues in the operating room? In 2017, Rob Hackett, an anesthesiologist from Australia, promoted the use of surgical hats labeled with providers' names and roles. His Twitter hashtag, TheaterCapChallenge, became widely popular worldwide and caught our attention too. Concurrently, our colleagues at the Stanford Adult Hospital were piloting the use of labeled caps in surgical stimulations. Participants found that labeled caps were very helpful in improving communication during OR sim. We took the opportunity to see if wearing labeled caps had value in the obstetric operating room during actual cases. Would going from this to this make a difference? To answer this question, we decided to do a study. In our study, we randomized 20 scheduled C-section cases to labeled versus non-labeled cap groups. In the labeled cap group, we printed adhesive labels with provider names and roles for all staff to place on their usual head coverings. We compared data between the labeled cap and non-labeled cap groups. We were present for all of the cases in order to observe intraoperative communication. We monitored how many times proper names were used and how many questions or commands were either unheard or unfulfilled. We also surveyed providers from each group to understand how often they were able to identify the names and roles of their colleagues. To get a better understanding of general perceptions about OR attire, we asked providers what effects surgical attire had on their ability to recognize others in the operating room and how they felt about the use of labeled surgical caps. In addition, we asked patients their opinion on labeled caps and collected open-ended comments from both patients and providers. These are the results from our provider survey about how surgical attire affects identifying colleagues. 91% of all staff agreed that surgical attire makes it difficult to recognize others. Staff responded.
Yeah, you should talk to Robin.
Right, staff responded that they felt they were able to recognize the roles of others 80% of the time, but only about half of the time were they able to identify the names of others when wearing standard OR attire. In our OB OR, the roles of colleagues is defined by where in the room they're working. With us OBs at the operating table, anesthesia providers at the head of the table, and pediatricians around the infant warmer. So the higher rate of recognizing the roles of others in our environment makes sense. Finally, all providers felt that the concept of a labeled cap was acceptable and that they would feel comfortable wearing one. This slide shows differences in provider survey responses between the labeled and non-labeled cap groups. Providers in the labeled cap cases reported they knew the names and roles of others more often than those in the non-labeled cap cases. Specifically, 92% of providers in the labeled cap group recognized they knew the names of others versus only 55% in the non-labeled group. And 92% in the labeled group reported they knew the roles of others as compared to 78% in the labeled group. Most importantly, providers in the labeled cap group felt that communication with their colleagues was easier than did those in the non-labeled group. 90% of staff wearing labeled caps versus 39% of those in non-labeled caps rated communication in the case they had just participated in as easy and without barriers. Here is our intraoperative observation data. Although these results did not reach statistical significance in our small study, we did see a trend toward more frequent name use, 43 versus 34 instances in the non-labeled group, and more missed communications in the non-labeled group, 20 versus 16. While none of these miscommunications led to errors, it was striking to see how providers used workarounds in order to get one another's attention when they didn't remember their names. For example, staff in the non-labeled CAP group were observed trying to get the attention of others by either struggling to make eye contact prior to speaking or resorting to using the old "hey you" when it was clear they did not recall the names of the person with whom they were trying to communicate. And in the labeled CAP cases, when initial commands were made without the use of name and subsequently not acknowledged, they were fulfilled after proper names were used on the second attempt. This happened in 3 separate instances and really points out how effective using someone's name is at getting their attention. Lastly, we asked study participants to give us their thoughts about labeled CAPs. Here are some of the comments we received from providers. It's hard to remember names, even after introduction at timeout. CAP name tags were extremely helpful in improving communication and ultimately patient care. I have been here 14 years and still have trouble with names since we are consistently getting new residents. Our OB patients are awake for their surgery, and labeled CAPs have an impact on them as well. All of our patients responded they liked the concept of the labeled CAP and thought they were a good idea. One patient stated, "CAPs helped with my anxiety, helped me to understand who was in the room and to recognize providers." So what are barriers to using personalized CAPs? Resistance to change, cost, and concerns about cleanliness are some of the reasons personalized cloth caps have not been promoted in the past. Cloth caps like these in the picture, embroidered with names, cost between $20 to $40 each, depending on where you get them and how many you buy. Are cloth head coverings safe to use in the operating room? Studies have shown that freshly laundered cloth caps do not contaminate the field and in fact shed fewer particles than disposable ones. The American College of Surgeons, the Association of Perioperative Registered Nurses, and the Society of Anesthesiologists all support the use of cloth caps in the OR. Our Stanford Children's Policy on Head Coverings in the OR states that cloth caps are acceptable, provided they are cleaned and changed daily. So what's next? We'd like to promote the use of labeled surgical caps for all operating room staff. Other institutions are taking notice and recognizing the benefits of labeled caps. After our CAP study was published, the UC San Diego took the opportunity to order labeled caps for all OR staff as part of their What's My Name initiative. And soon 800 of our colleagues at Stanford Hospital will be receiving their personalized caps thanks to the work of the Stanford CAPS team. I'm optimistic that leadership here at Stanford Children's will support this initiative too. I'd like to conclude with a short video so that you can hear firsthand what your colleagues have to say about labeled caps. But first, I'd like to give a shout out to my co-authors on the CAP study team. And thanks also to the Stanford Intercept team and Dr. Becky Wong for sharing their expertise in photos, to Dr. Steve Spall for photo editing, and to Kimber Padua for making the following video. I'll be happy to answer any questions after this short clip.
Part of the pilot project where we would put a label on our caps with our names. I found that people were using my name more often, which made me feel just happier in the operating rooms. I felt like I was being more valued as part of the team rather than just some anonymous face behind the drapes. And I did notice that overall I have been called by my preferred name more frequently since having this on, and people will oftentimes comment even in like the pre-op area, PACU area, that it's such a great idea and asking me how I went about doing it.
In the OR, sometimes we have a lot of people. We have anesthesia resident, anesthesia fellows, anesthesia attendings. On the OB side, also we have OB doctor, attending, resident, senior resident, first year, second year. So it's hard to keep up with the names. And sometimes we have a stressful situation. And at that moment, we focus on the field, and then we try to communicate with nurses. And that also, we have traveler nurses, and we have nurses that are with us all the time. Sometimes nurses from night shift that are coming for helping out. So yes, it will be very useful, especially in the OR environment, in the stat cases, to know the role and the names. So we are very communication within the team.
I think it's really important for us to have labeled scrub caps, because even coming in as a new intern, it was really difficult to know who's in the room. And now as a rising second year and going through residency, when we're in acute situations like deliveries, or if there's a code, it's nice to know who's in the room and who we need to call into the room. You know, if NICU's not there, who needs to get to the room to help our patient.
I've been called nurse, fellow, attending medical student, really anything and everything. Not uncommon to have our badges turned or not able to be seen. And because we rotate through so many different locations, we are not always familiar to everyone.
Easier for the nurses to have a head count and know everybody's last name, since they have to be recorded for C-section purposes or any surgical case. Easier to talk to people, know who they are.
And I participated in the surgical CAP study here at Stanford. And one of the things that I realized is how much we struggled before we did the study in terms of knowing everyone's name in the room. In the operating room, there's a lot of different people that are involved and a lot of different types of providers. We have different physicians, different nurses, different disciplines, from pediatrics and neonatology to OB, to some of the L&D staff, to the anesthesiologist. And often, you know, we're wearing regular scrub caps or masks in the room, and we don't often know who's who. And so by having names and roles on the cap, it really made it easy to identify who is who in the room and identify what role each person was in and what their name was. And it really made our communication and teamwork a lot easier in the operating room. And so this is something that I would actually recommend in other operating rooms and hospital-wide, because I do think it makes communication and teamwork in the room easier. I do think it improves our collegiality in the room and knowing each other and each other's names and roles in the room, and which makes our overall patient care better as well.
As an intern, now second year, starting during COVID pandemic, getting to know new staff, nurses, and colleagues and attendings with face masks, having labeled caps throughout the day in the OR especially made it really safe and welcoming for me to get to know somebody when it's just half their face, also have a labeled cap with their name.
Probably at least once a day, possibly even more. I'm mistaken for a circulator or scrub tech. And I think that can actually affect efficiency in the operating room, because I think that in the OR, it's very important to know who has what role. So I think that it would really help to have scrub caps that identify it.
Through certain small studies and through our own personal experience, that depersonalization in the operating room is something that anesthesiology residents do experience. And in some ways, it can have a negative impact on our day-to-day wellness in the perioperative settings. And making a simple change, such as verbal recognition of our own names, can potentially increase our own personal wellness.
There's a lot of people come in and out of the OR, and sometimes we just don't know their names. And
there are a lot of situations we're in where there's a big team, there's changing team members, and not everybody knows who everybody else is. And I think that an example of that would be in the trauma bay during traumas, being able to quickly tell who's from the emergency department versus who's from trauma surgery, and what everybody's role is could really help streamline communication.
All you're seeing is basically this much of a colleague space, and oftentimes you're also working with colleagues you haven't met before. And even though we do our timeouts where we all introduce each other, it's very hard to like remember that in an emergency situation. So it's nice when you're looking up the labels right in the front, and so you can quickly identify who you're contacting, and that way you use their name, and people respond so much better to their name than just hey anesthesia or hey XYZ nurse. So it's just much more beneficial for communication.
Okay, that wraps it up.
All right, thank you very much, Laura, for that very well organized and informative presentation. Maybe if we can have you stop sharing your screen, then we can have everybody see each other more easily. So I think you make an incredibly strong argument that the value of the program in enhancing teamwork and communication is greater than the cost or other associated risks of the program. So thank you for that great piece of work and strong argument. We have plenty of time for questions. Does anybody have a question or a comment? If not, I'll start off with a question or comment. You talked about some of the arguments or points of contention about the program. So maybe you can walk us through how many caps had to be purchased and for the obstetric area, and some sort of estimate of what the overall cost was.
So we, as a thank you to those who participated in the study, the staff that participated, offered to buy each person a labeled cap at the end of the study. So the only caps that we have are really from that program. And the purchase of the caps was funded by some grant money that we had. I believe the caps cost $35 a piece. And there's a limited number of them out there. We did also post the information on how to order one yourself. But if you're just ordering a single cap without the bulk order, the cost is a little bit more. I think it's $45 instead of $35.
And from an infection prevention and control standpoint, which I think is the other point people bring, if people have one hat, how is it logistically possible for them to have those, I believe the term was freshly laundered on a rotating basis, and how convinced are you that actually happens?
Yeah, I think you probably need about 3 hats for most people. That's how many I have, and I managed to keep them in clean rotation.
Okay.
Yeah, but you're right, 1 hat's probably not enough, because if you're working every day, and you're probably not going to have time to launder it in between shifts.
Laura or Lane, could you comment about, certainly unlabeled caps have been around forever. And I don't know what the compliance is on, how do you know that whoever's wearing a cap is a freshly laundered cap? It's not being issued by a sterile supply source.
I think you just have to trust that people are going to do the right thing. I don't think there's a way to really tell if your cap is laundered or not, unless it's visibly stained, right? I think Susan is raising her hand. Susan, do you have a question?
Yes, I just had a comment that I have a freshly laundered.
Nice cap.
Thank you. And I just wanted to comment that in this study we carried out in the days before the pandemic, but since the pandemic, as people are entering rooms with caring for COVID patients, I've heard from a lot of COVID patients that the only names they knew were the people who had a labeled cap, and how much they appreciated seeing that name, because otherwise they're not seeing our IDs. They're covered by our PPE.
I see that Tammy has her hand up. Tammy, would you like to make a comment?
I just wanted to say, I think it's such a great idea. And I know that the anesthesia department has, I actually work on the ped side, so we don't have labeled caps yet, but the residents have them and they come through and they're wearing them. And I think it really helps all of our staff to kind of get to know who they are, because as was mentioned multiple times in the video, like people are always rotating through. And so I think it's great for a sense of wellness and a sense of camaraderie. And I'm sure the patients are really benefiting from it. So thanks so much for presenting this study.
Thank you, Tammy. Great comments. I will add that we have had serious safety events where the lack of awareness of who was who in response to something like a code or things like that certainly were a contributing factor in the length of time it took to respond. So I think this is definitely a real issue that can be helped with such an approach. Other questions or comments? We have a written comment here. Neil submitted this. Neil, would you like to verbally state your question?
Yeah, sure. Thank you so much for the interesting talk. I was actually just wondering, as it sounds like this program is being adopted at some institutions and being rolled out across entire OR platforms. I think you mentioned at UCSD. Is there a plan with those rollouts for further study of the impact on this intervention, since the N obviously will be so much larger, to look at effects on communication and errors?
That's a good question. I don't know specifically of any studies, and right now we don't have the bandwidth to continue looking at this in a study setting. Kay, do you want to comment?
Well, I know that, this all started in Australia, and I know that they're trying to do some studies there. And I think there's some effort here from the Stanford side, if anybody's on from there, about studying it in a simulated setting. I think I saw Teresa was on the call, if she's still here. Yeah. Teresa, are you guys studying it?
Hi, Kay. Yes, we are just 3/4 of the way through of doing a study on the interventional platform at Stanford, which included all roles, and it was a joint project from both interventional platform, Department of Surgery, and Department of Anesthesia. So we actually had 1,500 caps made for our staff. We did a pre-survey, which definitely touched on, knowing people, whether you knew people in the room, and were you more hesitant in terms of approaching them when you didn't know their name. We are just getting ready to roll out our post-survey. And we had a total of, I did say over 1,500 caps, but we had a total of 837 people enrolled in it, with further people asking to participate. So we will share that data, and the response has been overwhelming from people in other departments besides the interventional platform that didn't get to participate, even to the point of going to the cafeteria and the server saying, "Oh, I wish everyone had their names on their caps so we could greet them in the morning." So Ling was also on the study, the director of interventional platform education. Do you have any additional support, Ling?
Hi, Teresa. Thank you actually for your tremendous amount of work. And I'm very happy to see all the videos here today, actually. A lot of them, the staff I recognize was from our recent rollout, and happy that this is really blossoming, and our next future goal is to get leaders buy-in, continue to support us. And I think within the Stanford side, the interventional platform is very supportive of sustaining this measure. And, Teresa and I are involved with Dr. Sarah Goldhaber-Fever Dr. Becky Wong, Dr. Osama Nazar, that we are in the team to continue to promote that. And we wanted to, share our experience and tools in the near future for other institutions, like UCSD, anywhere else, just like our emergency manual.
Yeah. Yeah, I think the main goal is, and Kay can speak to this, is it's not just the CAPS, it's really our goal of enhancing crisis resource management and bringing team steps, making stronger teams. That's really what we're hoping the CAPS will do. And I think now it's beyond hope. We have the evidence that show that that the strength by calling people by their name makes a team stronger, compels you to work harder for the benefit of both the patient and the team.
Thank you, Teresa and Ling. I think Susan has her hand up.
I just had another comment. We didn't really look at this, but there's been a lot of education about microaggressions and assumptions about who people are. And I think this is also something that particularly for our residents who come in, who people don't know them, there may be a lot of assumptions based on just implicit bias about what their role might be on the team. And this can be a way to counteract that and to minimize the stress of some of the microaggressions that are particularly our residents experience in surgery.
Very good point.
One of the most memorable interviews, like 30-second interview I did, was with an operating room assistant that we have. And he works here for half the year and then takes his money home to his family in Nigeria. And the other day I caught him and he was wearing his new name cap. And I said, well, has the name made a difference? And he told me, almost crying, that a doctor had said his name out loud. He couldn't believe that a doctor took the time to say his name. And it's just a heartbreaking video to watch. But that is what we want in terms of teamwork and respect.
I'd like to just add, which we haven't talked about as much as I think we should, is the patient reaction to all this. Yes, for OB, our patients are awake, but even so, in the main OR, when a patient comes in pre-op and there's just so many people coming into that pre-op area, the nurses starting the IV, the anesthesia, all of it's pretty overwhelming when people are anxious to start with. And I think we have to acknowledge that we don't necessarily do the best we could for our patients to decrease that anxiety. And I think this would be really helpful for that as well.
Yes, I completely agree, Kay. And we did encourage our pre-op and also post-op nurses and also the aides to purchase the caps, and they've been very pleased.
Thank you all. I see Lillian has her hand up. Lillian?
Yeah, I just want to add that, aside from UCSD, who adopted the name caps because of the study, another really large medical center in Texas also reached out to us and said, hey, because of, this paper, we're also going to try to implement it at our institution. And so given the interests around this, we decided that we're going to work on, I think with anesthesia, to create a website so that could serve as a resource for other hospitals to learn about the study and, get some guidance on how to approach the administrators at their institution to adopt this idea. And on this website, we have like links. We will likely have links to how to order, but also papers supporting that makes the case for why this is not an infection control issue. And the idea is that, you know, maybe if we generate enough interest, we can also even have more of a social media presence by creating a handle for this, and also encouraging sites who've adopted it to let us know so that we can create like an interactive map of everyone who's using this at their hospital.
When you all get that website up, we can certainly have that linked to a story on the Stanford Medicine Center for Improvement website as well, which could help drive traffic there. We could even have a story about it in the Stanford Medicine Center for Improvement newsletter as well.
Oh, that would be great.
Lisa Freeman, who's on, is the best person to contact about getting in both of those areas.
Good to know. Thank you.
Other comments?
I guess I can't seem to I don't know where the signal is to put your hand up, so I'm just going to do this. I'd like to know what the next steps are. I think, I mean, maybe we're preaching to the choir here and that we all believe in it. But what are the next steps for getting this done universally at LPCH? I mean, that was our struggle when we first did this study, and I'm wondering what we do next. We did the study, we proved it, everybody wants it, now what?
Well, I don't know if I'm the best person to answer that question, but I'll give it a shot. I think it's mainly making an argument to either perioperative leadership or other leaders that oversee perioperative that to make the argument, as you just have done, that it would be well worth the budgetary considerations to do this. And I can certainly help bring that up. And, you know, obviously the infection prevention and control aspect is the other argument that could potentially come up as well. And we just have to make sure that we make an argument that this would be done to meet all of those current requirements. But I think they're the key people that would come out of the perioperative budget, I would imagine, to get caps for everybody there and how many they would need and who would be included and potentially not included in that. Other questions or comments? Laura, any closing comments you would like to meet after hearing all of the comments and feedback?
Yeah, I just would like to echo Kay's question about, you know, what process we need to sort of go through to get everybody caps, because it does indeed sound like there's broad support for the use of labeled caps in the OR and even other settings in the hospital. So it'd be nice to sort of have a plan for that, how to do it.
I can certainly bring it up informally with the team, the executive team at our next meeting. And then I think the question becomes, do you try to get this in? It's not probably that big of a budgetary item through an off budget process now, you know, an unplanned budgetary item, or do you seek to get this into the budget for FY 2023? I think those are the two options, and I think we'd have to get an estimate to the cost prior to deciding which one is the best. But my guess is it's probably not a large enough item to prohibit it being an off budget cycle item.
Yeah, okay.
All right, well.
There's one raised hand, Lane.
I'm so sorry. Lillian, do you have another comment?
No, I don't.
Okay, great.
Sorry.
That's okay. All right, well, thank you, Laura and team, and congratulations on your great work. And thank you for taking the time to present that here today. If there aren't other questions, we will go ahead and give you back an extra 6 minutes. So thank you all for your time, and thanks again to Laura and the presenters. Take care.
Thanks, everybody.
Thank you, Laura.
Okay, bye.